Dear colleagues, I'm Christoph Diener from the Faculty of Medicine at the University of Duisburg-Essen in Germany. And I would like to present to you 5 interesting studies in neurology, which were published in September 2024. Let me start with migraine. We have a lot of information now about the pathophysiology of migraine, in particular migraine attacks. And here serotonin plays an important role, and we have triptans which target serotonin. For migraine prevention, we have 2 targets. One is CGRP, calcitonin gene-related peptide, and we have monoclonal antibodies targeting CGRP, and a new player, which is pituitary adenyl cyclase-activating polypeptide PACAP. The intravenous administration of PACAP can induce migraine attacks in migraine patients. And there is a new concept for the prevention of migraine, which is a monoclonal antibody targeting PACAP. In the New England Journal of Medicine, a research group in Denmark published a phase 2 trial in 237 patients in whom at least 2 previous prophylactic therapies were ineffective. They received the 1 dose of the monoclonal antibody compared to placebo. And the antibody led to a significant reduction in migraine days over the next 4 weeks. However, the 50% responder rate had a strong trend, but was not statistically significant. The treatment was well tolerated. And this means we need a much larger phase 3 study across 3 or 6 months to see whether this therapy really works. Potential patients for this new approach would be patients in whom monoclonal antibodies targeting CGRP or the CGRP receptor are not effective. My second paper also deals with migraine, in this case, acute migraine attacks, published in the British Medical Journal. Migraine attacks are treated in most patients with analgesics or NSAIDs, and we have 7 different triptans which are available. And recently, we have CGRP receptor antagonists such as rimegepant, ubrogepant, or zavegepant, and the 5-HT1F agonist lasmiditan. So far, however, we have no head-to-head comparisons of the new migraine drugs with the triptans or NSAIDs. Therefore, a network meta-analysis in the British Medical Journal analyzed 137 randomized controlled trials in almost 90,000 migraine patients. For the primary endpoint, which is pain-free after 2 hours, elatriptan, rizatriptan, sumatriptan, and zolmitriptan were the most effective treatments. Gepants and lasmiditan were significantly less effective, and their efficacy is comparable to that of NSAIDs. Now, the target group for lasmiditan are patients who cannot use triptans due to severe vascular diseases. The bottom line is triptans are prescribed far too rarely, and this is true for most European countries. And in particular, the most effective triptan, which is elatriptan, is practically not prescribed at all. Now, in terms of cost, triptans are now very affordable because they are off patent in the meantime. My third paper deals with the prodromal phase of Parkinson's disease, study published in Nature Communications. It is well known that REM sleep behavior disorders are a prodromal stage of Parkinson's disease. And the authors described 2 patients who were treated with acetyl-D-L-leucine, and this improved REM sleep disorder in both patients. But they also checked DAT-scan and FDG PET, and they also found improvement in these 2 very important diagnostic features for incipient Parkinson's disease. Now, this could be a potential new modulating treatment, well tolerated for the prodromal stage of Parkinson's disease, but this also means we would clearly need a large-scale randomized trial. Now, my next study is for stroke, and it's published in JAMA. We all know that elevated body temperature fever is a negative predictor of outcome, both in ischemic stroke and cerebral hemorrhage. And this is an open-label randomized study of almost 700 patients with severe stroke in the United States. They compared the prevention of fever with surface temperature cooling compared to standard therapy. They were able to decrease body temperature, but this had no impact on functional outcome. And this is a whole series of randomized studies. They all showed it is possible to lower body temperature and also, for example, to treat pneumonia, but this has no impact on functional outcome. And my last study deals with a very controversial issue also published in JAMA, and this is the treatment of symptomatic intracranial stenosis, which is much more frequent in patients in Asia. Now, this study performed in China compared balloon angioplasty in combination with dual antiplatelet therapy with drug treatment alone in people with symptomatic intracranial stenosis, 512 patients. They clearly showed a benefit for the primary endpoint, which was stroke or death within the first 30 days, or ipsilateral stroke between day 30 and month 12, hazard ratio 0.32. What is the problem? The problem is we already had 3 randomized trials, in this case with stenting. And these trials were either neutral or couldn't show a benefit for stenting. On the contrary, the stenting group had a clearly higher complication rate. Now, is it only the difference in the method, which is balloon angioplasty compared with stenting, or is there another explanation? And this means we need a second randomized trial with balloon angioplasty, preferentially perhaps in Europe and the United States. Dear colleagues, we had 5 exciting studies in neurology in September 2024. I'm Christoph Diener from the Faculty of Medicine at the University of Duisburg-Essen in Germany. Thank you very much for listening and watching.